we have some mic now? I'm Lyle Archibald, a longtime member of this society. I have the privilege of introducing Dr. Timothy Hannon, our next speaker. Dr. Hannon is an anesthesiologist at St. Vincent's Hospital in Indianapolis. He developed and currently directs the blood management program at St. Vincent. This program has decreased blood product transfusion over 30%, resulting in annual savings of 7,000 units of blood products and over $4 million. Dr. Hannon completed his medical degree at Indiana University and then served 12 years on active duty in the Navy. He completed his residency in anesthesia at San Diego Naval Medical Center, where he subsequently filled the role as Director of Perioperative Blood Conservation. In 1998, he entered an anesthesia practice at St. Vincent Hospital, and in 2004, he completed his master's in business administration at Butler University. He has received numerous military and academic awards and honors, and I will not review all those in the interest of time. He has lectured extensively and published many peer-reviewed articles and book chapters. He has also served on several Indiana State and National Blood Bank committees. He is currently the CEO and President of Strategic Healthcare Group, a consulting blood management organization. Dr. Hannon is not a stranger to Utah. He and his family regularly vacation in Park City. He has lectured at the University of Utah and at LDS Hospital in the past. We welcome Dr. Hannon.
Thanks, Lyle, for the generous introduction. Kind of hard to follow the past speaker, Dr. Jacobson. I'm an anesthesiologist, so that stuff gives me the willies, like I think everybody in the room. I'll quickly absolve all the surgeons and say, just whenever you have a complication, everything's an anesthesia-related complication, so that gets you off the hook most of the time. What I'm actually going to talk about today certainly has some interoperability with what he talked about, because what we're trying to express to you in a relatively short period of time today is risks and benefits and alternatives to transfusions. What are the responsibilities of the physician? What are the responsibilities of the system? And this even plays into informed consent. And as we're going to talk about, we're learning more and more about risks and benefits of transfusion on literally a monthly basis, but a lot of that information is not necessarily getting into the hands in the practice of physicians, and I think that needs to be accelerated. By way of disclosure, I have given some lectures for Medtronic in the past on blood management. I have no interest in any of their products or their company, and also I have a consulting group, but again, this is a CME talk, and we'll restrict it to that. I like to start with my definition of blood management. I also like to say blood management is not new. I've been working on blood conservation, blood management for about 15 years, first in the military and then at St. Vincent, Indianapolis, but it's become sort of a hot topic for, I think, reasons that you'll see. The short answer is blood management is optimal use of blood products. We don't like over-transfusion of blood products, which often occurs, unfortunately, but we don't like under-transfusion. We have the sort of crazy idea that the right patient should get the right product in the right dose at the right time, so optimal use of transfusions. The additional requirement, I believe, is that we have to be efficient in our use of resources. And blood certainly is a scarce resource. I think there's a huge element of stewardship in blood conservation, making sure that the community's resources used wisely. But knowing with some certainty after writing a book chapter on transfusion economics, blood is very resource intensive. There's a lot of people that touch blood. There are a lot of resources that interrelate with blood. There's medical technology time. There's nursing time. If you look at nursing as a great example, the average transfusion takes about 2 hours and 15 minutes of nursing time. 2 hours and 15 minutes of nursing resources per transfusion. So if any of these transfusions are unnecessary, we consume a lot of nursing resources. Beyond that, I think that blood management also incorporates things such as medical devices, laboratory tests, even pharmaceuticals. There's a blurry line between what is blood and what's pharmaceutical. And so our goal really is optimal, efficient transfusion therapy. With that sort of presumption that the goal of blood management is optimal, efficient use of blood and blood-related resources, is there any evidence to the contrary? And I like to show 3 slides that sort of are the problem statement that argue in the United States we really don't have optimal or efficient blood use in general. The first one looks at variation in transfusion practice, and this happens to be a cardiac surgery model, although I could show you similarly studies have been done in pediatrics, oncology, critical care, transplant, etc. The top study was a review of cardiac surgery transfusion practices published back in 1998, which was actually a 10-year follow-on study, and the study population was primary CABG, first-time hearts. And they're the same whether you do them in Salt Lake City, New York City, Indianapolis, or Minneapolis. They're the same patient. Yet transfusion rates for these patients varied from 27% to 92% across 24 institutions, a 4-fold difference. An international follow-up study was published about a year ago that showed internationally there's a 12-fold difference in transfusion rates for the management of what should be arguably similar patients, which is fairly eye-watering. We know within an individual institution, when you drill down in the walls of a hospital, if you look at 10 cardiac surgeons, 20 anesthesiologists, 30 intensivists, you'll see the same thing within the hospital, that there's a wide variation in transfusion practice within the organization. Some physicians rarely transfusing, other transfusing like it's going out of style. So point number 1 is just statistically, this doesn't make sense. This clearly can't be optimal if we have this much variation. The second slide has to do with sort of the megatrends in blood utilization, and at least I personally feel they're pretty interesting. The top one is about the shift from blood from the surgical to the medical patient. When I finished my anesthesia residency back in 1996 in the Navy, it's very, very safe to say at that time that most blood went to surgical patients, over 50% at the time. And that's why anesthesiologists need to be good about blood management. But there's a shift now, not just in the United States, but internationally. There's as much blood given to medical patients as to surgical patients for, I think, a couple reasons. I do believe as surgeons and anesthesiologists we have more tools and we're better about surgical blood conservation, but at the same time we have a graying population, and in particular oncology has become a huge user of blood products. Chemotherapy regimens that are saving lives are also consuming huge amounts of blood products. And at our hospital, St. Vincent, Indianapolis, which is a 700-bed community hospital, we saw a shift from 40% of our blood use going to surgical patients to 40% going to oncology patients over the scope of about 5 years. And much of our transfusions are outpatients. So the point being that blood management is no longer the purview of just the perioperative folks. There needs to be strategies for surgical and medical, adult and pediatrics, inpatient and outpatient. The next 2 bullet points compare us, the United States, to blood use in other countries, and like a number of things, we're sort of lagging the rest of the world. The United States has seen an annual increase in blood utilization by about 2 to 3% per year. To quantitate it, between 1999 and 2004, blood use in the United States increased by 16%. During that exact same time period, we are seeing most Western nations having a stabilization of blood use. And in fact, in the United Kingdom during that period, blood use declined by 8%. So we seem to be going in opposite directions. And if you want to quantitate that, I'm not sure why we went forward there. If you want to quantitate that, currently, in terms of blood use, we use 15% more blood per capita than Europe. That's red cells per thousand population, 44% more blood per capita than Canada, which is absolutely amazing. And when I heard a blood banker once say, well, we have different older, sicker patients here, more complex patients, I heard a Canadian respond, well, for goodness sakes, we don't live in igloos in Canada. So again, why is there so much of a gap? And we'll talk about it, that there's a nationalized focus on better blood use in Europe and Canada. The final sort of setup slide, I think, is the one that I hope you would say is most important to us as clinicians, is I don't really care if your hospital uses more blood than the hospital down the street, and I don't really care if the United States uses more blood than Canada or Europe. All I care about is, do we use it optimally? Do we use it appropriately? Do we use it in any sort of evidence-based, efficient manner? And that's where it really gets concerning, because the literature going back 20 years shows the same thing. When experts review transfusion decisions within hospitals, typically sitting down with charts and reviewing decisions against the hospital's own guidelines, you'll see between 30 and 70% of transfusions are judged to be inappropriate. 30 to 70% of transfusions viewed as inappropriate. And it could be that physicians are giving too much blood. It could be they're giving too little blood. It could be that they're giving the wrong blood product, the wrong dose of blood products, or the wrong mix of blood products, but not evidence-based transfusion therapy, not optimal. And again, it's been the same for some period of time. The reason this occurs, I think, comes down to two root causes, at least in my estimation, and I think that's good because then the solutions really emanate from these root causes. And the first one is a fairly startling discovery, and I don't know why it took me so long to discover this, is that most physicians that transfuse blood have never been trained to do so. Most physicians that order blood products have not been formally trained with a formal curricula on transfusion therapy, blood component therapy. Most medical schools spend maybe an hour or two, if they do it all, during the entire curricula, during a pathology rotation, talking about blood component therapy. Most residencies don't cover it at all. It's on-the-job training. And I say that to you as an anesthesiologist. We as anesthesiologists give more blood than any other specialty. We're the only guys that actually give it ourselves. We run it in ourselves. Most anesthesia programs, in my estimation, do not adequately cover transfusion therapy. So do you think that family practice doctors, orthopedic surgeons, cardiac surgeons get this? The answer is no. And all of a sudden it starts to make sense because what we get is on-the-job training. It's sort of habitual. It's linked more to the organization that we trained at than evidence-based principles. And I see this in cardiac surgeons because they have their own what we call party pack, what they like to transfuse to the bleeding patient after surgery. And the guys from the Texas Heart Clinic do it a certain way. The guys from the Cleveland Clinic do it a different way, and from the Mayo a third way as well. It's habitual. It's not evidence-based. It's not patient-centered. It's just kind of the way that they learned it. And that's why there's so much variation. What drives this variation even wider is that knowledge changes over time. So had I assumed that I had had the most recent information about transfusion therapy when I finished in 1996, it's not 1996 anymore. Knowledge changes over time, and physicians sometimes fail to update that knowledge. So have I updated my information with new paradigms for transfusion? And the answer clearly in many cases is not. One of the depressing statistics out of the Institute of Medicine is that it takes, on average, 12 to 14 years for physicians to integrate new knowledge into their practice. And we'll see, is that true in transfusion knowledge? Clearly, the answer is updating information, broad educational efforts, so we know when to give, how much to give, etc. As a minor aside, but a huge, huge point, nurses suffer the same gap. Nurses are trained in basic nursing school on how to administer blood products. It again is a see one, do one, teach one process, which should also be very concerning because most blood is not given by anesthesiologists. It's given by nurses on an order to physicians. And they're under-prepared, under-equipped to be able to safely administer blood products. The scope of this, just so you know, is that in the United States, we transfuse 29 million blood products a year, 80,000 a day, mostly by physicians who've not been trained to do so, mostly by nurses who are not trained to properly and safely administer it. Does that mean that all transfusion decisions are wrong? No, but it means that typically it's not based upon formal training, and unfortunately, often not on evidence-based principles. Clearly, the answer is better education starting at the local level. The institutional practice variation, why is there so much variation among hospitals in the United States, I think is also easy to explain. It's attention to detail. Those organizations that focus on better blood use, educate, monitor, track, have systems in place, will use less blood than those that do not. And these two issues are really what led us to our reduction in blood use at St. Vincent Hospital is broad education, continuing education for physicians and nurses on evidence-based practices and a strong transfusion committee with evidence-based guidelines, audit, feedback, and process improvement. So again, it's pretty straightforward. Well, let's get into a bit of evidence-based medicine and talk about the transfusion trigger and where should we transfuse today. Well, in red cells anyway, and that's what we'll focus our discussion on for the most part, it's really about do we transfuse patients at a certain level. So if we get a call from the ICU today and the nurse says, where should we transfuse Mrs. Smith? Do we transfuse her at the old 10:30 rule, 7:21, or something in between? And I think the best definition that I ever saw was actually in an editorial by a fellow anesthesiologist that said the trigger is really a hemoglobin level of discomfort in the prescribing physicians that's really not based upon the patient's physiologic condition. And present company excluded, I think that's absolutely true. Physicians tend to transfuse based upon a comfort level. I spoke with a group of hematologists, oncologists yesterday in California, and it's the same thing with platelet transfusions. It tends to be based upon a comfort level. And the working paradigm that many of you may have been taught, I was kind of taught informally, is older, sicker patients need more blood. And that really drives us in many cases to transfuse more liberally those patients with comorbid conditions. But again, in 2009, is that really what we should be doing? Well, I do want to show you a couple of slides that acknowledge that there is some rationale behind that. Does it make any sense that critically ill patients or patients with cardiac disease need more blood? Most of the studies are really based upon observational studies, and there is some credence to them. It's also interesting to say, as a side note, that we transfuse 14 million blood products a year in terms of red cells, and there's not a lot of science behind it, and it kind of starts here. Well, most of the studies have been done prior to the turn of the century, were observational studies looking at the impact of anemia in certain patient populations. Is there a relationship between anemia and adverse outcomes? And I'll show you a couple of representative studies. This is a large study published out of Canada by a guy named Paul Barry. He's a big guy in the area of blood transfusion, looking at almost 5,000 patients and the relationship between anemia and adverse outcomes. And what he showed fairly convincingly is if you're in the ICU and you have cardiovascular disease, that as your hemoglobin drops below a critical level of about 9 to 9.5, as you become more anemic, bad things happen at an increasing rate. And so the conclusion really becomes, if you are anemic below a certain level, if we transfuse to avoid that anemia, we will improve outcomes, and that's the therapy we should do, and it makes a lot of sense. Again, as an anesthesiologist, this was sort of burned into me. This anemia is why we transfuse to avoid adverse outcomes. Similarly, in cardiac surgery, and this is a representative study of about 8 studies looking at the impact of lowest hematocrit on bypass, there is a concern that we have anemia-related morbidity and mortality that should be properly addressed. So this particular study was a retrospective review of 5,000 cases out of Toledo, Ohio, very big heart center there, looking at the relationship between nadir hematocrit, lowest hematocrit, and adverse outcomes. The author was Habib, and Habib's conclusion was, as your hematocrit drops below about 22% on bypass, that as you become more anemic, bad things happen once again at an increasing rate. And those bad things included operative mortality, ICU and hospital length of stay, cost of care, and survivability went down. So the conclusion is, because anemia is harmful in these patients, we should be freer in our use of transfusions. And I actually include that as a direct quote that he said, freer in our use of transfusions, because to me it's a little bit inflammatory. What he's saying here is, why in the post-HIV era are we rationing blood? Why aren't we giving more blood, not less blood, to avoid this particular complication? And again, it does seem to be very logical. The problem with the Habib study, and actually most of the studies that have looked at the impact of anemia and transfusions, is they've been a bit one-sided. They're observational studies, and many of them have had a fatal flaw. And the fatal flaw is called confounding by indication. And I know you understand that, but let me just go ahead and elaborate. When you do an uncontrolled study and you try to figure out why something good or bad happened, you have to sort out the apples and oranges, all the factors that could have been contributory. Where it's really difficult to sort things out is if two things are closely linked or run together. So if every time a physician sees a patient that's anemic, they transfuse them, you have to account for both the cause of anemia, the impact of anemia, and actually you'd have to account for the transfusion as well, the therapeutic device as well. So in the study by Habib, although he showed that patients were anemic and that was bad, he also had data that showed as they became more anemic, they were exposed to more blood products. The more anemia, the more transfusions that they were exposed to. But interestingly, in his study, in his multivariate analysis, transfusions were not included in the model as one of the possible contributing factors, and that's the confounding by indication. So when we look at most of these studies that we've looked at for transfusion therapy, we're kind of left scratching our heads saying, what's the cause of harm here? Have we fully accounted for the reason they became anemic, which sometimes is not? Is anemia harmful to the patients? And it may well be. Or could the treatment of anemia, could transfusions also contribute to these adverse outcomes? And again, the answer simply can't be brought about by these types of studies. So the turning point for 21st century transfusion practice really came with what I would describe as turning the question somewhat on its ear. And the question that we've asked as physicians for years, is anemia harmful to our patients? And I believe it is. I don't think it's good to have little old ladies on bypass with low hematocrits. I don't think it's good to have critically ill patients in the ICU with low hemoglobins. But the question we want to know is, do transfusions make these patients better? Is there some therapeutic benefit of transfusing anemic patients? And again, interestingly, it was not well addressed until 1999. And in 1999, a landmark study was published called the Transfusion Requirements in Critical Care, the TRIC trial, again, published by Paul Hebert. Hebert is a scientist, did an observational study relating adverse outcomes to anemia, but said, well, now let's just prove definitively, do older, sicker patients need more blood? Let's do a randomized trial of transfusing at the traditional, although unproven 10-30 rule, or transfusing critically ill patients at a hemoglobin of 7, termed a restrictive strategy. Understand this was a radical departure in its day, and my comment is typically, I don't know how it ever passed the institutional review boards in Canada because it was such a crazy thought to think about transfusing restrictively critically ill patients. But the study was done with 838 patients. The results of the study, published back in February of '99, pretty much shocked the world because they were counterintuitive, even counter to what the authors had anticipated. It turned out that those patients that were transfused at the old 10-30 rule had substantially worse outcomes than those transfused at a hemoglobin of 7, and that's worthy of repeating. This was set up statistically as what's called an equivalency trial, saying, could we have equivalent outcomes? Could we get away with transfusing less blood? It turned out to be a superior strategy. The patients actually did better transfused at 7, worse transfused at 10, particularly looking at cardiopulmonary outcomes such as MI, ARDS, and angina. Similarly, mortality rates showed the same pattern. Mortality rates were higher in those patients transfused at the traditional 10-30 rule, lower in those patients transfused at a hemoglobin of 7. Again, fairly counterintuitive and very, very concerning data. So the conclusion of Hebert and his colleagues was that a restrictive strategy of red cell transfusions is at least as effective and possibly even superior to a more liberal strategy in our critically ill patient population, with one possible exception. And the exception was not all patients with cardiac disease. It was only a subset of patients with unstable angina with ACS. And it really didn't show worse outcomes in that patient population. It simply wasn't powered to look at that population. And as we'll talk about, that's kind of the third rail of anemia. So the editorial comment at the bottom of this slide is that this study is ranked as the #1 study that has changed transfusion practice worldwide, but how many physicians that order blood products on a daily basis in your hospitals are familiar with the study, or the hundreds of articles and editorials since '99 that have vetted this out as the best available evidence, not perfect, but best available evidence. And it would appear that the Institute of Medicine may be right. This is a 10-year-old study that, again, many physicians have not integrated into their practice. The next sort of piece of information I think gets even more interesting, because one of the carve-outs of Hebert, remember, was not all patients with cardiac disease, but those with ACS, patients that are having MIs or unstable angina. And this is, as an anesthesiologist, this is a very interesting physiologic model. The patient's heart is screaming out for oxygen by definition, right? They're ischemic. So you'd think that giving blood, which is a oxygen-carrying substance, would improve their outcomes. It seems like a no-brainer. Well, there's a cardiologist named Sunil Rao in Duke that questioned this as well. Is that true? Is there evidence that patients get better when they're transfused with MIs? So he could not convince his cardiologist at Duke to do a prospective randomized trial of transfusion strategies in MIs. First of all, only about 10% get blood, and now you talk about real heresy, that would be really crazy. So what he did is he did the next best thing. He did a database analysis. I've already mentioned that they can be hazardous, but he did some good things to make this a pretty decent study. He looked at over 24,000 patients enrolled in ACS trials. I don't know why this is auto-advancing. Looked at over 24,000 enrolled in ACS trials, meaning this is a very, very data-rich environment. He used over 30 different statistical variables, 5 different statistical models, including propensity scoring, or what's called pseudo-randomization, to sort out the independent effect of anemia and transfusions. What he found, again, was counterintuitive and fairly shocking. His conclusion back in 2004 when this was published is if you come in with an MI or ACS and you get a blood transfusion compared to a statistically matched patient, propensity scored matched patient, your risk of dying is 400% greater. Not 4% or 40%. The adjusted odds ratio of 4 means a 400% in excess mortality if you get that transfusion. A similar study published a year ago in the American Journal of Cardiology out of Israel, an observational study, showed the exact same thing. Substantial increase in mortality rate in a transfused MI or ACS patient compared to a matched patient that does not. And both also concluded the same thing, that the break point, although it's a little bit dicey, the break point for benefit versus harm in ACS appears to be a hemoglobin of about 8. Transfusing beyond a hemoglobin of 8 with an MI gets you worse outcomes, not better. And 8's a long way from 10, as many people still adhere to, and even further from a hemoglobin of 11, as was suggested in a pretty low-quality study by Wu, published back in 2001. So the conclusion of Rao in 2004, and I think reiterated by Aronson in 2008, is even if you're having an MI or unstable angina, there should be no mandatory, arbitrary transfusion trigger. As I tell our 130 cardiologists at our hospital, balancing myocardial supply and demand does not begin with transfusions. It's the last thing we should reach for, not the first. We should start with supplemental oxygen, rate control, etc. But again, interesting data. The final study, to bring it full cycle, and then we're going to talk a little bit about blood physiology to try to make some sense of this, is a revisitation of the problem of hemodilution on bypass. So in 2005, Habib published a study that said, hemodilution's bad, let's give more blood. The criticism of that particular study, as you recall, was that he did not look at the impact of transfusions as one of the variables. So we revisited this study, published in Critical Care Medicine in 2005, looked at almost 2,000 patients, again, same surgery, or same site, same surgeons, used 100% Luke-reduced blood products for anybody that cares, just means highest quality products available. This time looked at not just the impact of lowest hematocrit, but what transfusions also played a role. And what he found, again, was very interesting. Below 24% on bypass in this case, he shows that adverse outcomes increase, but when these anemic patients are transfused, their outcomes actually get worse, not better. So the anemic patient on bypass, according to Habib, when they get transfused, their renal injury rate doubles. The anemic patient on bypass that's transfused, renal failure rate quadruples, their length of stay goes up by 2 days, and mortality rate doubles. So in spite of the fact that the patients are anemic and not doing well, apparently transfusions do not improve their outcomes. And his conclusion in 2005 was in striking contrast. In 2003, he said anemia is bad, give more blood. In 2005, he said anemia is bad, yet transfusion seem ineffective as a mechanism to improve outcomes in our cardiac surgery patient population. The accompanying editorial to this particular article, also in Critical Care Medicine, was by Bruce Spiess, and the name of the editorial was this: Damned if you do, damned if you don't. And actually, if you care to look up the reference, it's very interesting because it's a dissertation in about 30 references of what I've tried to express for the past 20 minutes, that despite the fact that we transfuse 14 million units of red cells a year, we have very little evidence to hang our hats on in terms of risks and benefits to transfusion, and it is an evolving science. It's very, very interesting. And the damned if you do, damned if you don't situation is quite true, and I think has two implications. Personally, to physicians, what it says is we need to reevaluate our risk-benefit decisions in terms of transfusion therapy, and which is what we're required to do ethically, morally, medical, legally. When we see that anemic patient, we may be concerned about anemia, and again, I think anemia is not good, but we need to balance that against the risk of transfusion, again, and it is a damned if you do, damned if you don't, knowing anemia is harmful, yet transfusions may not improve outcomes and may worse, even make them more adverse outcomes. I think from a systems-based standpoint, there's a message here as well. And the message is that hospitals also need to put systems in place to try to minimize this really uncomfortable situation. And it happens regularly, unfortunately, in our hospitals that we put patients into harm's way, that we allow them to become bleeding or anemic patients by not intervening and getting to the situation where we don't have good options. And as both an anesthesiologist and a former Navy flight surgeon, I never like being in a situation where I don't have good options. And a brief example of that is what we see commonly, patients coming in for major surgery who are anemic and on platelet inhibitors. So the orthopedic patient coming in for a joint replacement that's going to lose 3, sometimes 4 grams of hemoglobin shows up on the day of surgery with a hemoglobin of 10.5 and somebody forgot to stop their Plavix. Even though Dr. Hannon makes a good decision to transfuse them, it was a bad decision to bring them in. So there's two parts of this that I think are a call to action both for physicians and hospitals. Well, let's talk about some physiology now and try to explain what seems to be an unexplainable paradox. How can patients be anemic yet not get better when they're transfused? And I think the answer is really extraordinarily simple, and it was something I certainly was not aware of as an anesthesiologist. Interestingly, the people that know this answer are your blood bankers and your pathologists, but unfortunately they don't give blood or transfuse it themselves. The answer is simply this. Although blood is a life-saving substance, and I believe that, or I wouldn't be a blood donor myself, it's an imperfect substitute for the blood that currently is in our veins, and that really explains the paradox. The blood that's in our veins and the blood that we get from the blood bank are not the same thing. They are both red, but that's where the similarity really stops. And we've sort of magically assumed in our operating rooms when the patient's hemoglobin drops from 10 to 7, we then order 3 units of blood, give it to the patient, we remeasure the hemoglobin, it says 10 again, that 3 grams of hemoglobin, those 3 units are working the same way that the blood was just lost. And again, that's not true, and the more we know, we see that sort of folly. So there's 2 things that really start to mitigate the ability of that blood from the blood bank to efficiently fix the problem associated with anemia. And the first one has become a very hot topic, and it has to do with storage lesions, and we'll talk briefly about those. What happens to the ability of blood to deliver oxygen to the tissues as it's stored over time? The second one, again, is a very basic fact that may be sort of a primer for you, is the statement that there's nothing benign about a transfusion. There's absolutely nothing benign about giving large amounts of foreign cells to patients, and we've kind of taken that for granted. So both of these should affect our risk-benefit decisions in 2009. So in terms of storage lesions, this is an evolving body of evidence, but I'll also say that there's over 20 years of information about concerns about storage lesions and their impact on patients. Well, let's talk a bit about stored blood. The FDA says that we can store red cells for 42 days, platelets for 5 days. Well, where does a red cell storage of 42-day come from? It basically comes from survivability under ideal conditions, that if you can take blood from a healthy volunteer and store it for up to 42 days in a blood bank refrigerator, if you return that blood under ideal conditions to the same donor, you can see about 70% in circulation at 24 hours, then that really is the primary directive for a 42-day outdate. Well, when I've asked blood bankers what other studies have been done about transfusion storage, it's interesting because there's not really much that's been done. And I say, well, have we looked at outcomes at day 21 versus 28 versus 35? Have we looked at tissue level effects? And the answer is no. I think we've sort of presumed that blood is like a pharmaceutical, that we take it off the shelf in a unit dose and we get the exact same response with each unit that we give to each patient. It's a very, very complex substance. It's a very complex system. Blood is living, breathing cells donated by almost 12 million different individuals in the United States, stored under somewhat standard conditions. Well, some of the things that we're starting to learn about that happen to blood that are very, very interesting. And the first one has to do with the lifespan of red cells. A red cell in your body lasts about 120 days, doesn't fare any better sitting in a blood bank refrigerator in a plastic bag at 4 degrees centigrade. So because the usual custom, which makes some sense, to give the oldest unit of blood on the shelf first, which is typically between 25 and 30 days, can be old as 42 days, what happens is about a third of that bag at the end of that storage life when it's dispensed, those cells are not viable. The issue is not that you got gypped by the blood bank, that they've given you sort of a short unit. The issue is that those cells that have not survived, those cells that have senesced, have not gone by the wayside quietly. This is a closed system, so as those cells start to break down, those byproducts accumulate in the bag. And the longer we store blood, the more these byproducts accumulate. And there are things such as plasma-free hemoglobin, cellular debris such as stromal ghosts, potassium, and very pro-inflammatory cytokines. The longer we store blood, the more of this stuff in the bag builds up. We typically don't think about this except in pediatric patients or in massively transfused patients, but there is some impact on every patient of this stuff in the bag. Technically, we call this stuff BRMs, biological response mediators, because patients respond. It's very, very pro-inflammatory and causes microcirculatory effects in the patients as we give these bystander products. And the impact of that probably depends on how old the blood is, perhaps the type of blood, and definitely on the patient population themselves. At the same time as we're getting more ill effects because of byproducts in the bag, we have functionality starting to decline in these red cells as well. Red cell, if you look in the lower left-hand corner, a red cell on day number 1 of storage is an 8-micron biconcave disc. It's very flexible and very slippery, and it's designed that way because it has to be. Red cells are 8 microns. The average capillary is about 5 microns. And what that means is red cells actually have to flex and deform and turn into little sausages to get to your tissues. The question is, if you look at red cells by day 21, 35, we store to 42, can they get there? Are they capable of doing that? And there's very, very good objective studies that say the longer we store blood, it becomes increasingly inflexible, it becomes increasingly sticky, the rheology properties are impaired with every single day. So blood, does it actually get to the capillaries when we transfuse, at least initially? And the answer I will tell you is we don't really know. All we have at this point are animal models, and the animal models are very, very concerning. The animal models, well, let me say provocative. The animal models show the same thing. The top one is a hamster model. The bottom one is a rat gut model. Both are designed to objectively look at the impact at the cellular level after transfusions. And they can do some neat things, such as looking at capillary flow and tissue level oxygenation. I'm lucky to get a hemoglobin in the operating room. But the models are these. You take blood off an animal and then replace it with either fresh blood that's a couple hours old, or blood that's been stored for 28 days. Now understand, this is rat blood and hamster blood that may not absolutely correlate with human blood, but the impact is this. When you give that animal fresh blood, you'll quickly restore tissue level flow and oxygenation with that fresh blood. When you give the same animal stored blood, you see a very concerning phenomenon. You get a decrease in capillary flow, you get a decrease in tissue level oxygenation. Technically, it's a malperfusion. You get a decrease in flow and tissue oxygenation, and in the animal models it will persist to up to 6 hours, at which time they sacrifice the animal. So the question is this happening in humans? Are we seeing these sort of storage lesions that could adversely impact microcirculatory flow? As the graphic illustration, I always like to show a fairly spectacular video, which I'll say again, this is a very anecdotal video. This is a human patient. It's a transilluminated buccal capillary bed. So you can actually see in this, you can see the red cells slipping and sliding, the little boxcars getting to the capillaries as they're supposed to do. In the same patient, post-transfusion, this is what the cytoscan looks like. You actually get a malperfusion, a sludging. Technically, in Southern California, we'd call this the 405 freeway on a Friday. You guys may have the same thing around I-80, but you actually see in this particular patient a malperfusion or a sludging at the capillary level. As I said, this is anecdotal. This is a single patient. This is non-scientific. I show it only because I don't have the animal videos in front of me, but objectively in the animal studies, every single time this occurs. And it starts to suggest a mechanism for some of the studies that we just talked about. So let's think about an MI patient with coronary circulation at risk. If we give something that could even transiently disrupt coronary circulation, would it explain why the mortality rate gets higher, not lower after that transfusion? Does it partially explain some of the renal injury data? Think about compromised renal capillary beds and giving something that can obstruct even transiently those renal capillaries. And then finally, Eber's study, which again remains the best available, could this storage lesion also account for some of the reasons why critically ill patients, in spite of the fact that they're anemic, do not seem to get better in that relevant range of 7 to 10. And many people have sort of glommed onto this as a possible explanation for studies that I would argue are pretty good. The extension of this literature is a very, very thorny issue, and it has to do with storage lesions and adverse outcomes and the implications on the blood collection industry. So there's 2 cardiac surgery studies that have been published. The one in black and white was out of Duke by Bosron. The one in the lower right-hand corner was out of the Cleveland Clinic, published a year ago in the New England Journal, that both showed the same thing, a very strong correlation, not necessarily causation, but a correlation between the age of blood that we give to cardiac surgery patients and some very, very bad outcomes. And this is very, very concerning. And you have to admit that based upon physiology, there may be some credence to these studies, but this is a very, very tough issue. I think to deny this or not talk about this, not bring it in the room, misserves your cardiac surgeons and your blood bankers, but we also don't have enough information to necessarily change our practice today. A lot of what I get is, well, Tim, do you only give fresh blood at your hospital in Indianapolis based upon these studies? And what I say is no, we do not, and in fact, I'm not quite sure what fresh blood is. Other than what they do in Iraq. I'm a Navy reservist, and what they do in Iraq is they say, Lance Corporal, you're A positive. Your buddy that just ran over an IED is A positive. I will give you his blood. That is fresh blood, arguably. Beyond that, I think it's hard to argue against the fact that a unit of blood that's 10 days versus 20 days versus 30 days is higher quality at those lower age points, but we don't have enough information in a very complex system to be able to judge when we should pitch blood. Should it be 14, 28, etc.? In the meantime, I always say this, although there may be some marginal difference in outcomes of transfusing certain high-risk patients at a 10-day-old point versus 20 versus 30, what I will show you in a minute is there is a huge difference in giving a patient 1 unit of blood versus 2, 2 versus 3, 3 versus 4 at any age of that blood. And that remains my primary focus of this talk is judicious blood use. Beyond storage lesions, which I think in and of themselves explain some of this paradox of anemia and transfusion, we also need to talk at least briefly about other things that are well established in the literature, but unfortunately not very well known to doctors that transfuse. Blood is not a benign process, and in fact I would say the most conservative people that I know in my hospital are blood bankers and pathologists. They're usually the first one to donate blood, yet the last one to accept a transfusion themselves. Is that hypocrisy? No. They believe that blood saves lives as I do, but they're fully advised of risk benefits and alternatives to transfusion. So beyond HIV and hepatitis, which are really now non-issues and a great testament to the blood collection industry, we've gone from 1 in 1,000 HIV to 1 in 2 million. There is a myriad of other risks associated with blood that will not go away, in fact, will never go away. If you want to be concerned about anything infectious that's not viruses, it's plain old bacteria. Bacterial contamination of platelets remains one of the leading causes of adverse effects because we store platelets at room temperature. They don't function otherwise. There have been some good effects, some good measures by the blood collection industry to reduce this, but they've also shortened the half-life of platelets through quarantining. Something that I bring up very pertinently with nursing staff, but it's important for you to know as well, one of the leading causes of death associated with transfusions remains wrong patient, wrong unit of blood. By one New York State study, they said 1 in 16,000 patients in the United States receives the wrong unit of blood. 1 in 16,000 patients receives the wrong unit of blood. Death associated with transfusions is about 1 in 400,000, some that involve this sequence of events that includes a bedside error by a distracted anesthesiologist or nurse, and it's a number that's not changed in 20 years. So as a flight surgeon, it really aggravates me that we've gone from 1 in 1,000 to 1 in 2 million for HIV, yet we seem to kill as many patients today as we did back in the 80s. And then there's a laundry list of other things that I don't have time to go into. On the bottom line, some of the alphabet soup, SIRS, blood is very, very pro-inflammatory, and in fact, because of the BRMs, TACO seems to be one of the leading causes of adverse events. That's transfusion-associated circulatory overload, TACO. A very good study out of Canada said 1 in 350 ICU patients get volume overload. Think of that, 1 in 350 patients in the ICU. Very, very high incidence. In fact, in orthopedics, this is set at about 8%. About 8% of orthopedic patients get volume overload, usually because of the sort of outdated use of predonation. Grandma's coming in for surgery, so I'm going to take a couple of units of blood off of her a couple of weeks out. She doesn't have time to regenerate it. She shows up on the day of surgery anemic, closer to a trigger. It's her own blood, and I have it right here, so I'll just shove it back into her veins and put her into failure. TACO is very, very prevalent. TACO is not benign. It'll put patients on the vent. It'll keep them in the hospital longer. I know personally of 3 fatal cases of TACO in hospitals that I've worked with in the past few years. So something as seemingly under the radar as volume overload needs to be calculated. And the big kahuna, thought to be the leading cause of death associated with transfusion, is called TRALI, transfusion-related acute lung injury, and I hope that by now you're familiar with this. So let's just talk briefly about it. The definition of TRALI by consensus conference is any acute lung injury within 6 hours of transfusion. Any acute lung injury within 6 hours of transfusion. Clearly, it's a diagnosis of exclusion. You have to rule out things such as volume overload, but guess what? Then it's TACO, which is also reportable. The incidence is thought to be amazingly high, probably 1 in 500 platelet transfusions, 1 in 1,000 plasma transfusions, 1 in 5,000 red cell transfusions, with a death rate somewhere between 5% and 20%. Extraordinarily high incidence, maybe 500 deaths a year in the United States. When I show this slide, the response from many physicians, actually nurses as well, is, Tim, I've been giving blood for 10 years, 20 years, 30 years, 40 years. I've never seen this. How could it be so prevalent? And I say, you have seen it, but you didn't call it TRALI. You called it pump lung, shock lung, ICU lung, trauma lung, Da Nang lung, or as Dr. Jacobson may say, just plain bad luck. We have seen this for many, many years associated with transfusions, but have not put 2 and 2 together. The pathophysiology is worth noting because it's very interesting. The one that gets the most press is the so-called femme fatale. It's associated with female plasma donors. What happens when females have pregnancies is they generate antibodies against that fetus. So the more pregnancies they have, the more these antibodies they will develop in their system. Unfortunately, some of those antibodies are against white cells, anti-HLA, anti-HNA antibodies, meaning that if that female donates blood and that contains plasma, such as FFP or platelets, and I happen to get that blood product that has antibodies against my white cell, that will actually attack my white cells as foreign. My white cells will explode my lungs, and I get this very, very vigorous ARDS such a picture. And again, very prevalent in relatively homogeneous populations. This cause of TRALI is so concerning that back in 2003, they banned female plasma donors in the United Kingdom. In the United Kingdom, since 2003, they've imported male-only plasma from the United States to the United Kingdom because of this cause of TRALI. And again, many people are still unaware of it. Many blood centers are going to a more selective plasma, male-dominated plasma, and I think that's going to help out. However, I think a couple years late, the other cause of TRALI will not go away, and it's the so-called 2-hit TRALI. And the docs understand, you understand 2-hit. The first hit is always something bad is going on. There's some priming. So the patient is sick, they're septic, they've had cardiopulmonary bypass, they're having a bad day. The second hit, unfortunately, is BRMs, our old nemesis. This patient that has some comorbid conditions now gets these additional inflammatory mediators, and that tips them over to lung injury and probably also renal injury and perhaps multisystem organ failure. And unfortunately, that cause of TRALI will not go away, at least with selective screening. The final thing to talk about in terms of risk benefits is probably the most important one at the end of the day, and it is TRIM, transfusion-related immunomodulation. This particular effect has been kicked around as controversial for years, but I do not believe it is, and we'll talk about that. The punchline of TRIM is this, is that when we give patients blood, we change their immune system in such a way as to make them more susceptible to postoperative infections, to cancer recurrence, to viral injury, things like that as well. And again, it's hard to sort of swallow that in one fell swoop because two things. This is the gift of life. How could it possibly do that? The other one is, the whole correlation versus causation. We know sicker patients get blood, so how do you sort this out? Well, how we sort this out, again, is very basic science that's tried and true. And you have to remember that blood is a liquid transplant. This is a liquid transplant that we're giving patients. So if you look at the cellular effects, they're very predictable, and they're in line with other sorts of transplantation response. What we get is we get increases in antibody response, the typical humoral immunity response, and that's why cross-matching gets harder and harder as patients get more blood. But we also get a classic anergic response from the cellular side of the house. As we give more and more foreign proteins, more and more foreign invaders to our patients, the immune system starts to be overwhelmed, starts to downregulate, and it's a semi-adaptive sort of a response. The patients start to tolerate the transfusions, and that's a good thing because they can live from that. But in tolerating that transfusion, unfortunately, they tolerate other things such as viruses, bacteria, and tumor cells. And again, it's very well worked out that as we give blood, we downregulate T helper to T suppressor ratios, we change natural killer cell activity, we cause decreases in macrophage migration. The more blood, the more downregulation, and so it starts to make sense. I also say to the older docs in the audience, which I'm quickly becoming one of those, is that we've known about this for years, because I can actually remember in medical school, one of the things we did was transfuse kidney transplant patients prior to them getting that allogeneic transplant. Why? They rejected their kidneys less often. Therapeutically, there's evidence that we gave blood for Crohn's disease patients, rheumatoid arthritis patients, patients with multiple spontaneous abortions. So the fact is we've known about the immunomodulatory effects of blood for some time, and the basic science is clearly there, and we have to deal with it. The issue then becomes fairly logical but very concerning going forward, is epidemiologically what we start to see is this, a dose-response curve. Because each and every unit of blood that we give to patients is a new set of donor antigens. Each and every unit of blood has a positive or, in fact, a negative impact on the patient's immune system and adverse events. And this is what an epidemiologist would expect to see. So each and every unit of blood that we give to patients, independent of other comorbid conditions, increases adverse events such as postoperative cardiac surgery infections, and clearly these are things that we want to avoid. Similarly, in orthopedic surgery, and again, I'm showing you a very small amount of the data that's available. In orthopedic surgery, there's a striking relationship, really an eye-popping relationship between units of blood transfused and postoperative infection, again, independent of other covariates, unit by unit. But it starts to also open up some solutions, or at least some behavioral modification. As you look at this slide, what you can clearly see is each and every unit of blood causes increases in adverse events. So why do physicians continue to perseverate on always giving 2 units of blood? If you're going to give 1, you might as well give 2. In the hospitals that we've audited, about 60% of all transfusions are double-unit red cells. Why? It's a habit. Beyond a habit, some transfusion committees in the past have sent nasty letters to doctors for giving single units of blood. Does that make sense in light of this evidence? I will send you a congratulatory letter if you give a single unit of blood. We do not double down on chemotherapy. We do not double down on antibiotics. Why do we do that with blood products? So relatively simple maneuvers such as a transfuse and reassess a single unit makes a lot of sense, not only in light of this, but in things like TACO. Volume overload can certainly be medicated. On the other end of the spectrum, I think there's bad news and good news. The bad news is that the curve continues on up. But I'm going to argue even in a trauma patient, if you've given 30 units of blood, you should still think carefully about the 31st, because each and every unit of blood causes an impact on your patient's outcomes. So it's thoughtful unit-by-unit transfusions. Even the amount of blood that we draw from patients starts to make a difference in our ICUs. The linkage between transfusions and renal injury, I think, starts to make sense based upon physiology. The linkage between transfusions and multi-system organ failure starts to make sense. This is TRIM, SIRS, TACO, trolley, all in patients that are not having good days. This is the Dr. Jacobson slide. There's a relationship between units of blood and mortality rates. Again, are you aware of this relationship? The odds ratio of 1.4 means a 40% increase in mortality in an ICU patient transfused compared to a statistically matched patient that does not. The U.S. equivalent of the study published by Corwin said 65% increase in mortality. We are required by the Joint Commission and common sense and ethical principles to advise our patients of all of their risk benefits and alternatives. Do we do that? Obviously, probably not. And then finally, the administrative side of this, the Dr. Archibald side of this, is what happens to resources. And this is why hospital systems are getting more interested in judicious blood use and blood management, is that there's a linkage between resource utilization and blood use that logically follows all these other things, TRIM, TACO, SIRS, trolley, etc. Each and every unit of blood that we give to a patient increases their time on the ventilator, their time in the ICU, and their time in the hospital, and these are extraordinarily expensive. And so hospitals are starting to wonder, do my cardiac surgeons give 5 units of blood per case or 6? That little of a difference starts to make a difference in terms of outcomes and resources in the hospital. And these are not cheap resources, by the way. Out of a book chapter that I wrote, just to show you the numbers quickly, it's in your handout. If you look at the linkage between transfusions and ICU days and ventilator days, which I believe is causal, you start to see that there's an extraordinary cost associated with this, that the average cost of a day in the ICU to your hospital is about $5,000 a day. Not the charge, the cost is $5,000 a day. I don't know why this keeps advancing, maybe because I need to talk even faster, is that if you look at these other costs, the cost of infections postoperatively run from about $17,000 to $30,000. The cost of bleeding in surgery costs about $30,000 in cardiac surgery. So if you want to spread these costs over the total cost of a transfusion, although you pay about $200 per unit of red cells on average in the United States, if you'd actually like to transfuse your patient, you're probably looking at somewhere between $800 and $1,800 to actually get that done because of nursing resources, tech resources, supplies, and any accounting for adverse effects. Again, bad news yet good news is by reducing unnecessary transfusions, and that is the message here, unnecessary transfusions, not only can we reduce the cost of blood, improve stewardship within the community, but save on a number of other scarce and expensive resources such as hospital beds and nursing as well. The final piece of the story is getting more interesting literally by the day, and transfusions actually relate to never events, and I didn't see on your agenda whether you're talking about these, but certainly your administrators are. Of course, never events was a term coined by CMS, the Joint Commission, Leapfrog Group, AHRQ, about things that should never occur in our hospitals. And we will certainly all agree we should never operate on the wrong patient, we should never operate on the wrong site, we should never give a patient the wrong drug or the wrong unit of blood, but never events now include things like we should never have DVT or PE in our patients, we should never have bleeding complications in cardiac surgery, and we should never ever have a hospital-acquired infection. Where it got really interesting was on October 1st of last year, and what I say is an evil act of brilliance by the CMS is that 11 of these 28 never events have been deemed non-payment events. So if these 11 things occur in your hospital will not be paid for the complication. What better way to spur innovation, right? And the things that are carved out in the first 11 include blood misadventures. A missed transfusion will no longer be paid for. Frankly, we should have never paid for it in the first place. But look at the other things. If a patient gets a bleeding complication in cardiac surgery, a $30,000 event that the STS, the Society of Thoracic Surgeons, says good programs have a 2.5% rate, you will not be paid for that. And then an increasing number of hospital-acquired infections are no longer being paid for. The linkage between transfusions and hospital-acquired infections, the odds ratio runs from 2 to 5. 200% to 500% increase in hospital-acquired infections in a transfused patient compared to a matched non-transfused patient. If you want to break it down unit by unit, each unit of nosocom or each unit of allogeneic blood increases hospital-acquired infections by 50%. A 2-unit transfusion doubles your patient's relative risk of a hospital-acquired infection. Are you familiar with this literature? Are your patients familiar with this literature? Are your administrators? The answer in many cases is not. Bringing us back to the point is it's not the elimination of transfusions that we need to do, simply judicious, thoughtful, unit-by-unit transfusions. So we really have kind of the perfect storm in 2009. Better blood utilization, better blood management is not new. The military's been doing it for years. Many hospitals, our hospital for 8 years, but we have sort of a conglomerations of things that's accelerating the pace of physicians and hospitals investigating better blood use. We do not have 12 to 14 years to integrate these new therapies. So back to the premise that I started with, where should we transfuse Mrs. Smith? If you get that call today, from the ICU nurse about transfusing Mrs. Smith, what I would say with some assuredness is the best available evidence for red cell transfusions in 2009 favors a more conservative, a more restrictive approach than we did in the past, much closer to a hemoglobin of 7 than a hemoglobin of 10, but with a very, very important asterisk. The asterisk is this. It's not that conservative transfusions somehow are benefiting from anemia. It's not that I'm saying anemia is good in our patient. I will argue that anemia is not good in our patients, and the best treatment of anemia is its primary prevention. What I'm saying is, in fact, although anemia may be harmful in our patients, transfusing with stored allogeneic blood in many cases does not improve outcomes or may make them worse in that relevant range of 7 to 10 where many transfusions decisions occur. And the paradigm that I was taught informally, older, sicker patients need more blood, is not only wrong, it's really quite hazardous. It's wrong because it may be true that older, sicker patients benefit from a higher hemoglobin. That's not the same as receiving more blood. They're two separate things. It's very, very important. The reason it's hazardous is this. As I will argue as a patient advocate, our oldest, sickest patients need our best decisions every single day. And so by transfusing these patients based upon our comfort level, rather than what the evidence says in 2009, we in fact give these patients a well-intended yet nonetheless harmful shove potentially into the grave. So we need to be very cautious about that. So again, I thank you so much for your kind attention. I don't know if we have time for questions, but again, if we do not, I'd be happy to speak with you in the hallway. Thank you so much. Yes, sir. I'm sorry, sir, what was the question? The question is, has anyone looked at the impact of altitude on this? One of the things that we have seen, one hospital we've worked with is Boulder Community, which is at 5,000 feet. One thing that I can tell you for sure is there's less anemia in that patient population than there is at sea level in Indianapolis. But in terms of any rational physiologic studies in terms of altering transfusion triggers at altitude versus sea level, like changing your baking settings as we have to do in Park City, I'm not sure of the physiologic basis behind that. I think that patients at altitude have the advantage of more red cells on average to spare, but I don't know that that changes necessarily the transfusion trigger. And I think that one of the concerns you're saying is that there's less ambient oxygen available, but people that are acclimatized to high altitude have also probably made some of those physiologic shifts. So again, I'm not familiar with any good quality studies that have looked at that. I will say an advantage at altitude, though, is there's less prevalence of anemia, so maybe it balances out. Right. Right. Again, there certainly is less ambient PO2, but one of the issues is, a slide I didn't show because we didn't have time, is that the only evidence-based therapy for tissue oxygenation in post-surgical patients is increasing FiO2. Because by simply increasing FiO2, there are studies that show that that actually increases tissue-level oxygenation, whereas transfusing stored blood does not, at least in the short term. So how many times has a doctor ordered blood, having the patient on room air? I'd say at least put them on some oxygen first before you reach for the unit. It's just really, it's a more thoughtful process, but I probably, there's more questions than answers, but it's aimed to be sort of thought-provoking. But good question. Thank you, sir. The question is there any blood substitutes? And my favorite military term, Navy term, is blood substitutes remain over the horizon. I can remember probably as a college student, if not a medical student, seeing the white rat underwater breathing. Do you remember that? You remember that, Lyle, the white rat breathing in the beaker? Nearly every company that's tried to bring blood substitutes to market has gone bankrupt, including, I think, BioPure is either about to or has gone bankrupt. The problem is it's a lot more complex than we had thought. The problem with most of the blood substitutes is they're nitric oxide scrubbers, which cause a variety of problems in the lungs, in the coronary circulation, and actually at the afferent arterial. And the physiologic studies that say most available blood substitutes, although D.O2 goes up and SVO2 goes up, tissue oxygenation stays the same or goes down. And basically it shunts oxygen around the capillaries. So we're not going to have any anytime soon, which is unfortunate. I think when we do get some, and maybe they'll get some next generation ones, and maybe in a couple years we might have them, likely it'll be very limited indications. It's the military that still pushes for them, not so much in Iraq as Afghanistan, something you could put in a corpsman's backpack and be shelf stable, pre-resuscitation perhaps, but they're also likely to be extraordinarily expensive. So blood substitutes have been a bit of a disappointment in this area, unfortunately. And as I always go back to, the things that you can do today, this afternoon, is better preoperative preparation and planning, more thoughtful, judicious, evidence-based practices, and then keep an eye on the horizon if these things come out. But unfortunately, no time soon will we see those. Good. Good. Well, I'm going to step away from the mic, but again, I'm more than happy to answer any questions. Thank you so much.